Welcome back to Concised Microbiology, an exam preparatory video with me, Kavi Tendral. Today we'll be seeing about Hypersensitivity-1 Part 1 from Immunology. If you are not subscribed to our channel, do subscribe for more interesting videos like this and as well press the bell icon so that you will receive a daily video notification. Today we'll be seeing about what is hypersensitivity, classification and type 1 hypersensitivity. Basically, hypersensitivity is the injurious consequence in the body due to repeated contact with specific antigen in a sensitized individual. This is called as hypersensitivity reaction. Now, how do they classify is the classification here for is the Gell and Coombe classification. They say that there is an abnormality in humoral or cell-mediated immunity following an antigen contact. Here, cell-mediated immunity, that is CMI, is related to type 4 and humoral immunity is related to type 1, 2 and 3. Basically, they classified hypersensitivity into two types. One is immediate and late. Under immediate it is 1, 2 and 3. Late it is 4. Next, coming to type 1 hypersensitivity, we'll be seeing about the hallmarks, types, allergen, experiments, mechanism, mediators, manifestations of hypersensitivity type 1, factors affecting and detection, at last management of type 1 hypersensitivity. First, coming to hallmarks of type 1 hypersensitivity, very simple. Now everyone would have seen this joke wherein which Vadivel would have been already exposed to a stranger who is trying to kill and now he is equipped to attack them. The moment they already he is more conscious about that strangers. So the moment there is a stimulus similar to that, he is now starting to attack, and this way is type 1 hypersensitivity actually is. So for that, there should be a contact with antigen, that should be a priming dose or the sensitizing dose for the first time, that is the first contact, and the next time will be a shocking dose. The moment there is a second time same antigen encountered by the body, that in turn causes type 1 hypersensitivity. How is that causes? Because there is sensitized B cell that produce IgE antibodies. Although there are many other changes, important changes is vascular changes. There is increased vascular permeability, smooth cell contraction, muscle contraction and platelet degranulation. These are all the important hallmarks of type 1 hypersensitivity. Coming to types, it is localized, it is called atopy, and generalized, it is called anaphylaxis. Next, coming to allergens. Basically, allergens could be of different types, because one allergen for one individual is not the allergen for the other, and thereby very commonly encountered allergens could be of allergies to nuts, especially peanuts, seafoods, weeds, ragweeds, foreign serum and vaccine, penicillin like antimicrobials, and then is bee venom or animal hair and so on. Next, coming to experiments demonstrating type 1 hypersensitivity. This is most important. There are three things. One is PK reaction or Prostak-Kushner reaction. This states or this proves that actually the antibody in the serum is responsible for allergy and it is transducible. How do they done it? Very simple. Now from the allergic individual they have taken the serum. From that he has injected into a non-allergic individual intradermally, and after that what he did is they injected the specific antigen for which the body allergic person has developed the antibody. So the antigen is also injected. After that they checked for wheal and flare. Basically that is the response, cutaneous response. The moment they injected this serum and antigen, there, that is PK, two persons, they have seen the wheal and flare, and therefore this reaction is PK reaction. The antibody which is responsible for this reaction is PK antibodies or antigenic antibodies. Later it is found to be IgE antibodies. Next experiment could be Schultz-Dale phenomenon. Schultz-Dale and Theobald's, both they have done with sensitized guinea pig. One important thing, Schultz-Dale is in vitro, Theobald's is in vivo. Both of them have taken the tissue and they have demonstrated hypersensitivity. Schultz-Dale is in vitro and Theobald's is in vivo. Next, coming to mechanism of type 1 hypersensitivity. Very simple. As I already said, first there will be an initial sensitizing phase and then the effector phase. It is all basically about the diagram. So once an allergen is going to come encountered by the body, and then the antigen presenting cell will take it. It will present to T cell, and the T cell will produce cytokine and in turn converts the B cell into plasma cell. This plasma cell now will produce IgE We know IgE is the important antibody, or is the antibody in type 1 hypersensitivity. This IgE will go sit or coat on the mast cell as well basophils. This is all about sensitizing phase. That is initial exposure with priming or dosing, sensitizing dose of antigen. Then is B cell will be secreting the IgE, basically the plasma cell. This is all about a first phase. Here the IgE is coated the mast cell and the basophils. Next, coming to effector phase. Here is the effector phase. What is the effector phase? That is re-exposure to the same antigen. Then that antigen will interact with the FAB region of IgE, and antigen is encoded at this, right? This is the FAB region of the IgE. And next is the memory T cell will also contribute to the supply of IgE, in turn causing increased granulation rate, degranulation rate. This diagram is an easy diagram to draw in exam. Again, allergen APC is processing to T cell, and this T cell will stimulate B cell into plasma cell. Plasma cell will secrete IgE. IgE will coat the mast cell and basophil, and re-exposure of this and same allergen or antigen will cause mast cell degranulation, in turn causing the vascular response what we have seen earlier. Coming to mediators, what are the mediators? We know mast cell is one it is known for producing histamine, releasing histamine and serotonin, and thereby the primary mediators are the mediators which is already present in the cytoplasm as granules. So histamine, serotonin, everything is released, and therefore there is vascular permeability, smooth muscle contraction, what we have seen earlier. And next is, it is eosinophil has to come there. So eosinophil chemotactic factor, and at any site neutrophil has to come first. So neutrophil chemotactic factors will be released, and as a result of that there will be eosinophil neutrophil chemotaxis, and then this causes destruction. That is cellular matrix will be destructed. For that the protease action is needed, and therefore this is also a primary mediator. So from mast cell it is primarily the histamine, heparin, serotonin. For chemotaxis of these two, eosinophil, neutrophil, there is chemotactic factors, and for destruction of the extracellular matrix is actually happening, for that is the protease. Next is secondary mediators. Secondary mediators are the ones which is produced after the primary mediators. That is platelet activating factor, because after that there will be platelet aggregation and degranulation, leukotrienes, prostaglandin, bradykinin, other inflammatory cytokines. Coming to how the person will manifest. So it is all dependent on the site or the route of allergy. So considering the nasal, the airway, the GI tract, and as well the intravascular injection, like that. So here the allergen will increasingly produce type 1 hypersensitivity if it is injected in the vessels, and then the order goes from vessels and then for nasal route and GIT, like that. So if it is by airway, it causes hay fever or allergic rhinitis, that is upper airway. If it is lower airway, it causes asthma. GI tract, it causes food allergy. Skin, it causes atopic dermatitis and drug allergy also. Systemic manifestation could be severe dyspnea, hypotension, and there will be angioneuritic edema, vascular collapse, and death. These are all the manifestation of type 1 hypersensitivity. Late manifestation are due to neutrophil and eosinophilic infiltration, because there is neutrophil chemotactic factor, eosinophil chemotactic factor, which is released as primary mediators, and therefore this will chemo attract, and it will call the neutrophil and eosinophil at the site, in turn cause inflammation. Neutrophil will cause thickening of the basement membrane, and eosinophil is one of the factor that is going to specially cause inflammation and persistent bronchial asthma. Factors affecting type 1 hypersensitivity could be because of three things which I've already said. Allergen to one individual could not be the allergen to other, because there's a genetic loci that encodes a protein for regulating the immune response to the particular antigen. Next is dose. We know that if it is a small dose, there is persistent IgE only. If it is a large dose, there is only for transient time IgE response, and then there is a shift to IgG. Now, one important thing is Th1 response and Th2 response. This we have discussed in complement video. If you have not watched it, I have given the link in the description to check it out. Here Th1 response will always inhibit type 1 hypersensitivity. Th2 will stimulate. It is because the interferon gamma. There should be always a balance in Th1 and Th2 response to the antigen. Now how can we detect this tests? It could be skin prick test, radioimmunosorbent assay, wrist, and RAS, radioallergen assay. So coming to first skin prick test, what they do is just take a potentially specific antigen, they'll keep it on the forearm, and then they'll prick it. So how they done it? They take a suspected potential antigen, inject it intradermally or they percolated. Allergen sensitized individual will show local wheal and flare response, which develops at the site of inoculation. So what is the use is it is very cost effective comparatively. A large antigen can be tested at one time. Disadvantage it, we can have the risk of sensitizing to a new allergen, and as well there are potential risk for anaphylactic shock. Coming to wrist and what is wrist and RAS? Wrist is here is immunosorbent assay. So we are actually dating the total serum IgE. As in RAS, it is allergosorbent assay. So we are detecting the allergen specific IgE. Here in these two tests, the first we'll see immunosorbent assay. Very simple. They will take a disc. The disc is coated with anti-human IgE because we are going to test the IgE. So IgA kandupidikkanumna we have to put it anti-human IgE. Now after that we are adding the serum. The serum has human IgE. This anti-human IgE and IgE will react. But how we can know that reaction is by adding a radio-labeled anti-human IgE. The amount we add it, the reaction is taken. We can detect the captured IgE. Coming to radio allergens, so allergosorbent assay, we are testing the allergy specific IgE, right? So we are taking the disc, that allergen is coated on the disc. So when we add the serum, if at all the IgE which is specific to the allergen is present in the serum, that will bind, and that in turn, how do we know that it is binding? So that we are adding the anti-human IgE that is a radio label anti-human IgE to that will detect by the reaction. Management of allergy is basically only avoidance of allergen is the first line of management, and then we can go for hypersensitization. What is hypersensitization is we have to repeatedly inject this antigen subcutaneously. Why this is done is it is on the basis of initially there will be transient IgE and there will be shift to IgG, so that there will be decreased risk of allergy hypersensitivity. And second important thing is there's Th2 to Th1 response. It is because interferon gamma will suppress IgE. Other treatments could be of starting on monoclonal antibodies, especially on bronchial asthma, and the drugs. Those drugs are first is antihistamines because the primary mediator is histamine, so we can give antihistamine. Next is epinephrine. We know it is one of the life-saving drugs in hypersensitivity. Then it could be of cortisones. At last, it could be theophylline or cromolyn sodium, and that's it. Thank you so much for your patient listening.